Good morning and good afternoon and good evening, everyone. We'll give just a few seconds here to let everyone join. I see the number of attendees going up, so give us just a few seconds and then we'll get started. Great. So as we're still having some people join, let me go over just a few logistics before we start officially. Next slide. So we're obviously using Zoom today. You're probably familiar with it. We'd like to ask for everyone to use two particular parts of Zoom. You should see the Q&A box at the bottom of your screen. If you don't, click the three dots more button and get access to the Q&A. If you have questions for our panelists, please put them there. Our panelists do not necessarily see the chat. So put any questions for the panelists throughout our whole webinar today. We'll answer some of those in writing. We'll answer others here live, and we'll have access to all of them provided after the webinar. You may also use the chat. Please do. You're very welcome. We would love to know who is here. So you're welcome to introduce yourself in the chat. And if you have additional comments or you have any logistical concerns for our team running the webinar, please put them in the chat. Okay, next slide. Great. So I see we have a very healthy audience now, and welcome everyone. Again, my name is Nathan Blanchett. I'm a program director at Health Systems Insight, and it's my pleasure to moderate this third webinar in a four-part webinar series called More Health for Today's Money, which our strategic purchasing for primary healthcare program is putting on. I will give some brief remarks this morning and then this afternoon. And then we have a packed agenda with lots of great content on a very important topic to share with you. Next slide. So I want to start with a slide. If you've joined us for webinars 1 and 2, you've seen this slide before. But we share it again to reinforce the idea that this context is the context that has motivated this whole webinar series, and that is tightening health financing and growing primary healthcare demands. So first, we know that governments are facing rising fiscal pressure from both debt and inflation. And evidence has shown that this is indeed leading to declines in public health spending. We also know, all of us, I'm sure, are aware of the drops in external development assistance. The World Health Organization has reported a 23% drop in ODA from 2024 to 2025 and projected declines in the future of 19 to 33% in bilateral health aid. These declines are then exacerbated actually by increasing demands on primary health care. That comes from growing populations, from increased expectations to fill gaps in universal health coverage, and rising pressures to respond to pandemic risks and climate change and other threats. Together, the real point here is visualized by this chart, that funding is known and projected to be short of where it would ideally be. You can see here that it is well short of minimum public spending benchmarks for universal health coverage in low-income countries on the left, lower middle-income countries on the right. In that context, we believe it is vital to find and help countries find all sources of value that they can get from their existing resources. And that is really what this webinar is all about. Next slide. So reflecting on that context, we happen to have had the privilege of working for about 7 years now across 6 countries, Burkina Faso, Indonesia, Kenya, Pakistan, the Philippines, and Uganda, working with governments and partners on a variety of health financing needs, strategic purchasing, and others to basically strengthen primary health care under real-world constraints. As we have reflected on that experience and the current context today in the world, we have found that there are four interlinked priorities that we find to be highly valuable right now, and it's the motivation for this webinar series. The first one was using resources more strategically at the district and county level with better information about inputs that district level managers have to work with. Our second webinar talked about improving coherence between mixed purchasing programs that exist in most countries. Our third webinar today is going to focus on value that can be found in improving the efficiency and effectiveness of fund flows to facilities and how those facilities can use those funds. That'll be our topic today. And then finally, on July 22nd, we'll have our last webinar that really takes principles from the first three and applies those to an area that is so important for primary healthcare, that being improving the financing for medicines and supplies. If you have missed our first couple webinars, next slide. If you've missed our first couple webinars, we hope we can direct you to our YouTube channel and our website. All the materials, the full recordings, the PowerPoint presentations, even the Q&A and synthesis reports are there. So I won't take time because we have a packed agenda for today. I won't take time to vocalize the key takeaways here from the first one and two, but those are available to you all, and we'll put the links to those in the chat. Thank you. So here's our agenda for today. We are focusing on how countries can ensure that scarce health funds efficiently reach and can be effectively used by primary healthcare facilities. After my remarks, we'll go into, we're very, very proud to launch today in partnership with ODI Global, who I'm sorry, I meant to mention that from the very top. We're co-hosting today with our colleagues from ODI Global, so you'll hear from them. And we're proud to launch a major multi-country synthesis report that will be available starting today on this very topic. And the synthesis of that report will be presented in the first part of our webinar. We'll then go to see some more specific application at the country level of these ideas with presentations from Pakistan and Tanzania. And then we're going to open up to a really rich panel, which will be moderated by someone who was quite instrumental in starting all of this work, Nirmala Ravishankar from the Gates Foundation. And then we'll close for today. Next slide, please. Before we dive in further, we do want to share and make sure we're aligned on a couple key terms that you'll hear us use today. One is fund flow efficiency. So when we say this, we are referring right now to how well funds move from budget allocation or from an agreement from a purchaser to pay to the front line, with efficiency associated with minimum delays, minimum fragmentation, transaction costs, administrative burden, or other losses that are not improving health. When we say fund flow effectiveness, we're referring to whether funds that reach facilities can actually be used to address service delivery needs because they're predictable, they're flexible enough, they're aligned with the facility's own powers and responsibilities, and supported by adequate authority and capacity. Next point. We will use these guide markers so you know where we are and what we're trying to achieve today. Throughout our agenda, we're really starting with the what. That's going to be the synthesis report that I described. We'll see why this matters at a country level, the so what, in our country presentations. And then we hope that our panel will cover both of those things, but also take us into the now what. What can we all do about this as we look into the future? Okay, one more thing from me, and that's actually to hear from all of you a bit before we dive into our first synthesis report. There should be a poll that pops up on your screen and we would love to hear from all of you this kind of motivational question before our first synthesis. So in your country, which routine, either your country that you live in or a country that you focus on a lot, which routine service delivery problems can government primary care facilities usually address using their own funds? And you should be able to select more than one. So if we could give you a few seconds to answer that question, and we'll see what kind of reflections we have in the group today. So staffing gaps, drug stockouts, minor repairs, cleaning, small equipment, or none of the above. All right, I think we'll go ahead and close that poll. Okay, very interesting. Thank you all for answering so quickly. Interesting. Minor repairs or maintenance being the top one. Okay, great. So keep that thought in mind as we now turn to our first presentation. Next slide. So we're going to explore the main fund flow challenges that prevent primary healthcare resources from reaching frontline facilities in a timely, predictable, flexible, and usable way. And to start us off with that, next slide, we have two excellent speakers with us today. We have my colleague, Pee Wee Ko, who's our country director in Philippines for Health Systems Insight, and Tom Hart, the Senior Research Fellow in Development and Public Finance for ODI Global. And this was a joint effort to conduct these six country cases and a quite large synthesis report that we're happy to start sharing with everyone today. So with that, I'll turn it over to you, Pee Wee and Tom. Pee Wee?
Thank you, Nathan. And as Nathan said, to frame today's discussion, Tom and I will share findings from HSI and ODI Global Synthesis Report. Next slide, please. Financing the Frontline, which examines how public health facilities receive, manage, and use public health funds across 6 countries: Burkina Faso, Indonesia, Kenya, Pakistan, the Philippines, and Uganda. The report contributes to today's theme by looking at fund flow efficiency and effectiveness from the PHC facility point of view. Rather than only looking at national financing arrangements, the study follows resources all the way to the front line. From that perspective, the key question is not only whether PHC financing exists somewhere in the system, but what can actually reach facilities, what facilities can access and manage, and whether those resources can support efficient and effective service delivery. So to show why this matters, let me briefly start with the motivation for the study. So as a key resource of accessible, continuous, and reliable care for a large share of the population, PHC is essential for achieving universal health coverage. Strengthening financing for primary health care is therefore not only about increasing resource levels, but also about ensuring that funds can be accessed and used at the facility level to maintain service readiness, continuity, and responsiveness. For this reason, there has been growing global interest in direct facility financing and greater facility autonomy outside of improving purchasing for PHC, since facilities need autonomy and decision space to respond to incentives and local needs. But we still have limited comparative evidence on what facility financing arrangement actually looks like in practice. This is why HSI and ODI Global undertook this descriptive and inductive analysis to help identify how resource rules and capacities interact at the front line. Rather than beginning with an ideal model of how financing should flow, the study first asked how financing arrangements actually operate across different institutional contexts. This then gives us a grounded basis for understanding where fund flow, efficiency, and effectiveness are gained or lost, and for identifying specific reform areas for action. So as mentioned, this cross-country analysis looks at 6 countries where HSI is implementing the SP4 PHC project. These countries differ in income level, decentralization arrangements, and financing mix, including the relative roles of national and subnational government budget, social health insurance, external aid, and out-of-pocket payment. At the same time, they also share important features. PHC facilities often sit within decentralized systems, depend on multiple funding streams, and receive many inputs in kind from higher levels of government. This combination makes them a useful comparison, which allows us to ask what resources actually reach PHC facilities and what facilities can do with them. Next slide, please. Building from that motivation, this analytic framework shows how we documented, compared, and analyzed across the 6 countries. Starting on the left side of the slide, we document the service delivery and governance context, how PHE facilities are organized, who owns and manages them, and how responsibilities are divided across national, subnational, and facility level. Then moving to the middle of the framework, we document 2 core components of facility financing. The first is financial flows to facilities, what fundings exist, who the purchasers are, what type of funds facilities receive, how funds are allocated or paid, when they are released, and what they can be spent on, and whether funds can be carried over. The second is facility PFM systems, budgeting, cash release, banking, spending authorization, procurement, reporting, staffing, and financial management systems that can determine whether funds can actually be accessed and used. We want to highlight the interaction between these 2 middle boxes in this framework. Financial flows define the resource envelope expected to reach facilities, while the PFM system determine how that resource envelope is translated into spending through budget approval, cash release, banking, procurement, and the likes. Together, we analyze how financing and PFM arrangements shape the outputs shown in the center, whether budgets are credible, whether fund flows are predictable, whether resources can be executed efficiently, and whether there is sufficient accountability over facility-level funds. So moving further to the right of the slide, this usable decisions space shape what facilities actually purchase, such as hiring staff, procuring medicines and supplies, investing in infrastructure, or paying for operational costs. We then examine how this contributes to service delivery, particularly in a context where direct cash is only one part of the PHE resource envelope, and many essential inputs are often financed, procured, or managed at a higher level. So overall, the framework helps us analyze whether financing and PFM arrangements give facility enough usable decision space to support efficient and effective frontline PHC delivery. So next slide, please. As an overview of the findings across the 6 countries, we identified 5 recurring patterns in how PHC facilities receive, manage, and use the financial resources. First, context shapes the financing problem. So PHC facilities operate within tiered, mixed, and often decentralized systems. Authority over financing, staffing, procurement, and oversight is frequently divided across levels of government. Second, financial flows are multiple and uneven. Facilities receive only part of their resource envelope as direct cash, while many core inputs still arrive in kind. The often multiple funding streams that do reach facilities differ in timing, earmarking, reporting, and carryover rules. Third, PFM determines usability. Even when funds are allocated, budget rules, cash release, banking, procurement, and reporting requirements determine whether those funds can actually be accessed and spent. This is especially challenging when PHE facilities have limited finance staff, tools, and system access. Fourth, decision space must be realistic. Effective autonomy means scope authority for the functions facilities can realistically manage. Since many core inputs are managed at higher levels, PHC facilities need usable discretion over complementary routine and time-sensitive needs. And fifth, responsiveness depends on usable financing. This points to a systems approach matching financing functions to the level where they can be managed best, centralizing where scale and control matters, and delegating where responsiveness matters. So next slide, please. So going more in depth into these, we'll first discuss what financial resources reach PHC facilities. Across the study countries, facilities may receive a mix of government grants, government transfers, grants, insurance payments, user fees, donor funds, and community contributions. But only part of the overall PHE resource envelope reach facilities as direct usable cash. Many inputs still arrive in kind, as mentioned. And another key point here is that subnational government often acts as intermediaries in fund flow for PHC facilities. Funds may pass through provinces, counties, districts, municipalities, or local governments that manage allocation, release, approval, and reporting. Our report does show that all public facilities in the country studied receive some form of direct financing, but the scale, source, predictability, and usable discretion vary considerably across countries and facility types. PHC facilities generally receive more limited direct financial flows than hospitals. The Philippine fund flow diagram on the right illustrates these fragmentations. Funds come from and may move through national government, ministries, social health insurance, local government accounts, private insurance, and households. Each stream may have its own rules. This matters because fragmented funding makes it difficult for facilities to plan across their full resource envelope, but may not be able to use them for the problem at hand. Another stream may arrive late, another may be flexible but too small, another may require separate reporting. So when we talk about fund flow efficiency and effectiveness, we are asking whether funds are not only allocated, but released, accessible, and usable for real service delivery. So I'll pause there and hand over to Tom, who will take us deeper into the PFM systems and facility level realities that determine whether this financing is actually usable in practice. So Tom?
Thank you, Pee-wee. And it's a pleasure to be here this afternoon with all of you. Can we have the next slide up, please, on the presentation? Thank you. So it's ultimately the PFM arrangements that are going to influence whether facilities are able to use the funding that's allocated to them effectively to improve the quality of service delivery. As these PFM rules determine how funds are planned for, released, spent, and reported on. And the first point I want to highlight here is that Pee-wee's already mentioned the fragmented funding flows that many facilities receive from different, whether it's through user fees, through government grants, through health insurance schemes. And these different funding flows may have different PFM rules, such as different budgeting reporting requirements, and also crucially for the management of those funds and the management of facility level spending may be released at different times. And we have to remember the constraints on the staff at PHC facilities that are typically managing these, in that most PHC facilities don't have dedicated financial management staff, but they may have some community-based oversight of groups to oversee their spending and approve their budgets and so on. In the countries we looked at, the main exception we found to this was Puskesmas in Indonesia, which do typically have a dedicated accountant. But in most other primary health facilities in the other countries included in the study, it would be their administrative or clinical leadership who are having to do these PFM functions. So we have to remember when we're looking at the processes, these are not falling on specialized accountants. These are falling on the general clinical and administrative staff at the facility. The second area to highlight is where budget and expenditure control may limit the flexibility of spending at the facility level. So a first constraint here is that there are budgets may be prepared on behalf of facilities by local governments and not take adequate account of their needs. So we found that across Burkina Faso, Indonesia, Pakistan, certain classes of PHC facilities in each of those countries have limited involvement in preparing budgets, which is typically done for them by the local government. We also find that funds may be tied to line items, earmarked, or approved work plans. And if environment, that's the ability to shift funds between different budget lines during the year, has limits on it, or requires higher level approval, which can take time, then facilities may have resources in one category or one line item in their budget while facing shortages in others. And just as on the kind of budget preparation point, the facilities may have limited involvement. Similarly, many in the Philippines and for many Kenyan facilities, the local government approval is needed for any expenditures, where co-signatory from the district health office is needed for approvals, and this will slow down spending especially where the facility and the DHO office are not co-located and they're having to travel otherwise or take time to get just to get the approvals for spending. A third area where we found that facilities had challenges was where a significant part of their funding is demand-based funding, such as insurance reimbursements or user fees. They have to forecast these at the start of the year and then include them in their budget. And if those forecasts are incorrect or they've not been able to do them accurately, then they may receive funds that they haven't budgeted for and that they can't spend for. And again, going back to the staffing point, these are not kind of dedicated financial management staff who are having to do these calculations of what resources they can expect, but the general clinical and administrative staff. A third challenge is accessing the cash, even if it's been allocated. So this is because maybe it hasn't been released, payments are delayed, or it's being held at higher levels. And I think we'll come back to this, but I think this is particularly where central and local governments should be focusing their attention on making sure that the funding that is coming to local governments is predictable and reliable. I spoke already about the fact that where facilities may have their own bank accounts, but that they may need co-signatories and other approvals that make getting the cash time consuming and challenging. We do often see a way around that where facilities are provided with more routine petty cash advances. And I think this is the main way in which Pakistani facilities, primary healthcare facilities receive their funding. But this can typically only be used for small and tightly controlled expenses. The last area is really about a policy and monitoring point, which is that there's fragmented reporting creates only partial visibility for local and national policymakers around what their facilities are using this funding for. So facility level spending is often only reported through local governments on an aggregated basis. So you can see what the total spent by facilities was, but not what each facility spent. The expenditures are often reported through different systems as well. And this manual recording and limited financial management information system at the facility level make it hard to track the liquidity and spending and also link to outcomes. So this matters for policy because if local governments and national governments do not have timely and reliable records about what facilities are spending, it's hard to take policy decisions about whether facilities are receiving the right amount of cash, whether they need more, also to check on what they're using, and ideally also to link this to outcomes so we can see which facilities are efficiently using their funding to increase the amount of services they're providing and which are not doing so well and may need greater management attention. Next slide, please. A further point is that the appropriate facility autonomy is shaped by the structure of local government. So across the countries we looked at, there's wide variation in the scale and scope of responsibilities of subnational governments. So the chart on the right shows the average population size served by local governments and the average number of facilities managed by each local government. So Philippine municipalities and Burkina Faso's communes serve relatively small populations compared to Kenyan counties and Pakistan's districts in Khyber Pakhtunkhwa province, which serve populations of around 1 million. And this variation in population size is also accompanied by substantial differences in the number of facilities that each local government manages. So this ranges from roughly 1 to 20 facilities in the smaller local governments to more than 100 facilities in Kenyan counties, which manage, and for Kenyan counties, they manage both the primary level facilities and some hospitals as well. So these differences mean that when we think about what facilities are expected to do in terms of carrying out their financial management responsibilities, the support that they can expect and the type of oversight they can expect from their local government units will be very different. So larger administrative units, such as Kenyan counties or Pakistan's districts, may have greater access to fiscal resources and expertise, but they need to coordinate and oversee these extensive facility networks. So this is the kind of context in which we would expect to see substantial facility autonomy should be beneficial. Smaller local governments, such as the Philippine municipalities, um, may be closer to the facilities, but they themselves may face constraints in technical capacity and financial flexibility as well. So this is just to show that the kind of appropriate type of facility autonomy, the type of support and relationship with the local government that we can expect is not one size fits all and is going to vary depending on the structures of local government and the type of facility network they oversee. And the degree of facility autonomy in each system is going to vary on these structures. And where expanding facility autonomy is desirable, that this will need the matching support, procedures, and accountability from the local governments as well. So, Pee-wee,
So
back over to you.
thanks, Tom. Next slide. And building on this, we again document what facilities actually purchase and attempt to answer which functions are appropriate to manage at the facility level and which are best managed at higher level. So across the countries, primary care and lower level facilities generally had narrower purchasing authority than hospitals. They were more commonly able to spend on routine operational needs such as utilities, minor repairs, basic supplies, outreach, similar to what was answered in the poll, while the hospitals, with their increased capacity, generally had broader purchasing authority, including larger operational expenses, more regular procurement of medicines, equipment maintenance, and in some cases, infrastructure or payroll-related functions. So this matters for efficiency because functions need to be managed at the level where they can be carried out with the least waste, delay, and administrative burden. But it also matters for effectiveness because facilities need enough usable authority to maintain readiness and respond to local service delivery needs. So small routine, time-sensitive expenditure like minor repairs, outreach, transport, and emergency supplies can directly affect whether services continue smoothly. So this points to a more nuanced view of facility autonomy and brings us to the reform questions. So handing it over back to Tom. Next slide.
Great, thank you. So in terms of what can we take from the analysis in terms of thinking about reforms, and as Pee-wee said, the first thing is to think about where does scale matter, and where does expertise matter in the financing functions of facilities. And those are things which should be tended to be keep centralized. When I say centralized here, that doesn't just imply the national government, but may imply the regional or local governments as well. And these are things like payroll, pool procurement, major equipment, and infrastructure. And what is appropriate to delegate to facilities where responsiveness matters, where acting quickly matters as well. And that is the kind of minor repairs. We don't want facilities, waiting days to get approval so that they can buy some new light bulbs or repair a door handle or so on. In their utilities as well, in their outreach work, in procuring emergency supplies where needed, and in transport and temporary support. So these are all things where we should expect facilities to have sufficient funds to carry out those day-to-day arrangements without any delays. So this means enhancing what central systems do best, strengthening what facilities need to manage locally through the routines operations, but also making sure that autonomy is paired with effective support and oversight as well. Aligning the PFM operations with the frontline realities where there aren't generally dedicated financial management staff, and making sure that budget lines, approvals, procurement thresholds, reporting are all simplified and also aligned across different funding flows as well. And I think particularly making sure higher levels of government, making sure that funding reaches facilities reliably and predictably, whether that's insurance agencies making sure that they stick to the turnaround times when the facilities have made requests for reimbursement, whether it's making sure grant flows, but all of those keeping that focus on making sure the funding gets there reliably and predictably, and making sure that we sequence reforms according to the capacities at both facility and local government level and in the context of the local government systems in which these facilities are managed. So that may mean using graduated or differentiated autonomy depending on the capacity that is available at the facility level and at the local government level. But it also means that making sure that we've got the data to take those decisions effectively. So making sure that facility level funding is visible and can be analyzed, and ideally is also linked to output data in terms of the quantity of services that are being provided by each facility as well. Thank you.
So to close this, through this synthesis framing, we attempted to answer the what about PHE facility financing. It's not only about whether resources are allocated, it's also whether funds reach facilities in ways that are predictable, accessible, flexible, visible, and usable for frontline service deliveries. So now we'll be moving to the country presentations, which will take us to the so what, why these challenges matter for PHE facilities, including how they affect day-to-day service delivery, facility autonomy, and effective use of scarce resources. So next slide, please. With that, I'm pleased to hand over first to Nida Hamid Afridi, a governance and PFM specialist with 15 years of experience in public sector reform, health financing, and policy innovation in Pakistan. She will share about Pakistan's experience with primary care managed committees. After Nida, we will hear from Dr. Peter Binyaruka, senior health economist at the Ifakara Health Institute in Tanzania, who has over 15 years of experience in health financing and health system research. Peter will share Tanzania's experience with direct facility financing. So Nida, over to you.
Thank you, Bibi. Next slide, please. Hello, everyone. As Bibi said, I'm Nida Hamid Afridi from Health Systems Insight. Today, I represent Pakistan's experience from Khyber Pakhtunkhwa, where primary care management committees, or Sven, can you please stay on the first slide? Thank you. I'm just introducing it. So where primary care management committees, or PCMCs as we call them, created a last mile fund flow mechanism for primary healthcare facilities. PCMCs are not only a facility autonomy reform, but a practical mechanism for moving funds closer to the point of service delivery, and also giving facilities a mechanism and a structured process to make spending decisions in response to the immediate operational needs that they have. Next slide, please. So just to build the context, Khyber Pakhtunkhwa has a large primary care delivery network serving about 40 million people through roughly around 24 primary healthcare facilities, and government health spending per capita was about $16.3 in fiscal year 22-23, and the out-of-pocket also remains pretty high at 57%. The key bottleneck for us is not the size of the budget, but it is actually how usable the budget is at the facility level. So the primary care facilities were allocated budget, but largely received in-kind support through district-level processes. And the facility managers had very limited authority to make even small operating expenditures. So if they have to do minor repairs, or if they want to replace basic items, or they have to make a local purchase, which is urgently required, they would still require a district approval for it. And the evidence that we have seen, it shows that 70% of facility transactions were below 50,000 PKR, which roughly is around $180, I guess. Yet these small transactions could remain stuck in lengthy approval processes. So what happened is that this created a mismatch between local service delivery needs and the administrative system that is required to respond to those needs. And when these small repairs, or a stretcher in the facility, or medicine and equipments, or outreach needs are delayed, service readiness deteriorates and public trust in frontline facilities declines. Next slide, please. So what was KP's solution for it? In 2020, KP introduced a decentralized spending mechanism through PCMCs, and the design had 4 components. First is the governance structure. So it's a 5-member committee with 2 facility staff, the medical officer of the facility, who is the chairperson, and the PHC technician in the facility as the secretary. And there are 3 community members, including a village council representative, which now was discussed as a local government representative. In July 2024, the Department of Health mandated that each facility must include at least 1 women member. This composition, if you look at it, combines operational expertise with community accountability. The second component is the financial architecture. Each facility operates a dedicated commercial bank account. Fund sources to these facilities are provincial budgets, which could be from the recurrent side or the development side, 90% of the retained user fees, and donor or philanthropic contributions that may reach the facilities. Withdrawals require dual signatures from the chairperson and the secretary, who are all representing the facility. If you look at the scale is pretty modest. So if all fiscal year 25-26 allocation funds are released to the facilities, to the PCMCs, the average available funding per facility per month would be $100. And if you compare it with the revenue that they retain, it would be per facility $19.3 per month. This is based on the average OPD volume and the standardized user fee structure that we have. So this is pretty modest. It is not a huge amount of money which goes to the facility. The third component is the delegated spending authority. PCMCs can finance minor repairs, emergency medicines, they can hire outreach staff, they can hire temporary staff for janitorial services, for other small bits in the facility, and they can do the oversight of assets and attendance. The design, I would say, therefore, provides autonomy, but it has some guardrails to it. And last, and the fourth component is the operating cycle. So the facility which has the PCMC would meet with this committee once a month. They would record the minutes of that meeting, and then they would do the withdrawals from the bank account that they have for the needs that have been identified during the meeting. They would do the spending, and then they would retain the receipts of those spendings for record. So this actually is operational speed while preserving an audit trail. Next slide, please. So what are the implications for this? HSI's expenditure and qualitative assessment shows that when facilities had cash on hand and authority to spend, they used the mechanism to address the readiness gaps. The expenditure analysis that HSI conducted shows that 439 facilities which had usable data were allocated 691 million, and out of the 691 million, 91% of the expenditure went into infrastructure and repair, while the remaining 9% went to equipments, medicines, and other items. And just to break down the other items, it could be a tissue box in the facility, it could be stationery in the facility, it could be any small bit that a facility requires. This does not mean that infrastructure is the only priority for primary care. It shows that facilities had accumulated these basic readiness gaps, that the normal approval system was not resolving quickly. On the other hand, the qualitative study, which was conducted in 24 facilities, found that facility staff and community members viewed PCMC as a highly valuable useful mechanism for facility management, especially when there were no financial influx from the province, and they were retaining their revenues, which helped them sustain their facilities. So from a fund flow perspective, the finding here is that small, flexible, facility control funds can translate into rapid improvements in operational readiness, especially when the bottleneck is not the scale of the procurement, but it is the local responsiveness, the responsiveness of the system to address those needs. I admit that the first wave of PCMC spending was dominated by infrastructure, but a mature model, once the PCMC is still not very old, once a mature model should allow more balanced spending over other facility needs. Next, please. The process was not without challenges. Next slide, please. Thank you. The process was not without challenges, and the PCMC experience also shows that the challenges, please, Swen. The PCMC experience also shows that facility autonomy does not solve the entire fund flow. The reform moved decision-making closer to the facilities, but sustainable financing required solving upstream governance constraints. The first constraint was the source of financing. So in fiscal year 21 to 23, so these are 2 years basically, 1.93 billion was allocated, out of which 691 was used, which means a 36% of the utilization rate. Much of the early finances was linked to time-bound development funding rather than a predictable recurrent fund. The second constraint was the release. So even when the allocations were included in the budget, releases did not automatically come through. In fiscal year 23-24, 24-25, as shown in the chart, had allocations, but they did not materialize into releases. But in 25-26, 320 million were allocated and 103 million were released, reflecting progress, but also showing that the predictability of the releases is mainly central. And the third constraint was facility level data. Once funding was released, distribution required information on the facility needs, the functionality, the mechanisms that the committees are following, their activity, and any readiness gaps that the facility may have. IMU is the authority which records all the data on indicators from the facilities. So IMU indicators and the other facility level data were consolidated to guide the distribution plans. And the technical lesson here is that direct facility finances requires more than a budget line. It must be treated as a recurring operational function with defined release triggers and distribution criteria, and topped up with financial controls and monitoring as well. And without these elements, I think autonomy remains formally delegated to these facilities, but then it still remains operationally fragile. Next slide, please. Finally, what are the lessons? So the lessons that we came out of PCMC experience, we had 3 technical lessons. First was the political buy-in. It is necessary, but it is not the only thing that you require. It was not sufficient in the case of PCMCs. So the political support helped launch PCMCs, but the reform became operational only when the support was converted into fund flow rules, spending authorities, approval pathways, and accountability mechanisms around it. So autonomy, therefore, cannot remain a single policy decision. It is a set of operational processes that determine whether facility managers can legally, confidently, I say confidently because we faced it in PCMCs, and quickly use those resources at hand. The second lesson was that the reform needs an institutional home. Facility autonomy cannot depend only on individual champions. It cannot rely on project teams that are here today, but tomorrow they would be gone. In KP, what we did is that we created a dedicated PCMC unit, which helped anchor responsibility within the department, and also created a clearer point for coordinating all issues related to PCMCs, be it finance, operations, facility related, district related, whatever issues arise, they were directed towards the PCMC unit. Last but not the least, the third lesson is that the data architecture is central to the sustainability of the reform. Securing an allocation is not enough. If the system cannot track releases, utilization, committee meetings, absorption bottlenecks, and changes in service readiness, it is not useful enough. Data makes the reform visible, targeted, and easier to defend. So for me, the overall message over here is that autonomy can unlock frontline responsiveness, but sustaining it still requires predictable funds, still requires institutional ownership in the department, and it still requires usable data at hand, which can be used for decision making. And for LMICs, I would say the sequencing would also matter. So you have to design the expenditure rules, you have to have a set of guidelines, you have to create the institutional owners and build the reporting system before expecting facility autonomy to scale. Thank you. Over to you, PV.
Thank you, Nita. Handing it over now to Peter. Peter?
Thank you, PV. Good morning, good afternoon, good evening, everyone. So I'll be sharing the experience from Tanzania with regard to direct facility financing, the DFF. Next. So just to start with the context, Tanzania has a population of around 70 million, and the GDP per capita is 1,200 USD, and it's a lower middle income country in East Africa. The total health expenditure per capita stands at 50 USD. And the general government health expenditure as a percent of GDP is at 2%, which is below the 5 recommended target. And in terms of the general government health expenditure as a percent of government health expenditure has been stagnated below 10%. It's at 8%, which is also generally below the 15% Abuja Declaration target. So within Tanzania, we do have multiple sources of financing the health sector. As you can see, the breakdown of fund sources in terms of expenditure from the National Health Account, the graph on the right-hand side. You see the government source in the blue bars has been increasing over time from 2019-20 to 2023-24. But also followed with a slight increase in insurance contributions or share of insurance to the total health expenditure, but with the recent decline towards 10% in 2023-2024. However, we have just started the universal health insurance, so with expectation maybe the share will go up. The out-of-pocket has been fluctuating from 32 to 20-something%. But on top, we see the donor financing has clearly been declining over time, as you can see. The primary healthcare level in Tanzania includes the district hospital, health center, and the dispensary at the lower level, and we do follow align with the referral structure. So before the DHFF reform in Tanzania, a couple of bottlenecks or problems which were existing, and the DFF was meant to try and address those challenges, which is still ongoing. Not all the problem or challenges have been addressed. First is the limited financial autonomy at the PHC level, because the funding were just ending at the district level, the local government authority. So the facility, the Frontline were not that flexible in terms of how they plan and how they use the resources. The second is about fund flow through multiple layers. So the fund were just going to the district, and then the district can decide on behalf of the facilities. So sometimes the facilities can just get the funds or get resources which they were not of much importance. The third is about the multiple fund flow. So the idea of fragmentation or the context of fragmentation. So multiple fundings and multiple channels of financial resources being allocated to facilities, of which even with the existence of DFF, I would say this has not been fully addressed, but at least the DFF is a platform which multiple fund could align within that framework to ensure that we harmonize the funding flow to the frontline provider. The last problem is poor alignment between the funding and the local needs. As you can imagine, if the district level are planning and budgeting on behalf of facilities, they are not that capable to know all the needs within the catchment area of those facilities which they are planning for. So it used to have that misalignment in terms of what is being spent vis-a-vis what is needed to the front line. Next. So the DHFF reform in Tanzania started in 2017-2018, which was launched countrywide. The design includes the direct transfer of funds to primary healthcare facility bank accounts. So facilities recognized as a spending unit in the chart of accounts. In terms of sources which constituted the DFF, to the large extent is the Health Basket Fund, which includes the earmarked fund for the health sector, which is collected, contributed with development partners and the donors, but also the health insurance funds, which are just reimbursement to facilities from health insurance agencies, also are direct taken to the facility bank account as part of the DFF. The key actor of this reform, the government entity, the Ministry of Health, Ministry of Finance, Prime Minister Office, Regional Administration, and Local Government, were the lead on this, but also the Health Basket Fund donors or partners who are contributing to the Health Basket Fund, of which the contribution is done on annual basis, but also this is aligning with the SWAP approach, the sector-wide approach framework. The Health Basket Fund has an MOU of 5 years to align with the health sector strategic plan, which runs for every 5 years. And the current MOU is from 2021 up to 2026. And the current partners or donors, 9 partners who are contributed to the basket at the moment, including the World Bank, which has the highest contribution. In terms of policy basis, these reform were introduced to align with the health sector strategic plan, but also the health financing strategy, the PFM reforms. There was a revision in terms of chart of account, but also introduction of DHFF guidelines. The motivation for reform, which resonates with what I just mentioned in the previous slide, the delay in fragmentation in fund flow, weak alignment of funding with local needs, lessons from other reforms which were implemented in Tanzania before DFF, the hierarchy of RBF and pay for performance, but also the capitation and grant reform in the education sector. The DFF has an allocation formula, and more specific for the Health Basket Fund, which is just allocated to facility through adjusters in terms of weight. So the catchment population has a weight of 40%, the remoteness in terms of distance, 10%, and the 50% in terms of performance on service utilization, inpatient and outpatient utilization. The Health Basket Fund is paid on a quarterly basis and the insurance on monthly or 60 days. In terms of coverage, the funds which are channeled through DFF, in terms of total revenue of the PHC level, if you check in the bank account, it's just approximately 2/3 of the revenue is actually through the Health Basket Fund. And this covers 20% almost in terms of operating costs. So to the large extent, the DFF covers most of the operational expenses, the like of drugs, in case the facility has an out of stock, the Central Medical Store Department has out of stock, then the facility can use those funds to procure commodity, but also to cover for utilities and renovation. But almost 80% is non-DFF, which includes the salaries for personnel, capital, and also the in-kind allocation to the Central Medical Store Department, which the non-DFF fund are managed centrally. In terms of fund management, facility in charges are the one who takes that role with support of accountant for facility which has accountants, but also the health facility governing committees does the oversight. In terms of accountability, there are multiple levels of approvals, but also digital systems which are in place, the plan rep for planning and budgeting, but also facility financial accounting and reporting system, FAS, for expenditure tracking and reporting. Next. So what are the implications or the effect with regard to introduction of DFF so far? So evidence has been increasing. A number of studies have been conducted in the country just to try and understand what are the effects after the introduction of DHFF in Tanzania. So I just included here a few selected domains. So the first one is about service utilization, of which most of the studies actually are showing an overall increase in utilization or service coverage on primary healthcare level, but with strong effect actually on maternal and child health services. And there's no evidence with respect to health outcome. Basically, there's no study which has been conducted. In terms of quality, medicine, and infrastructure, a lot of evidence do exist, including the study which shows compliance with quality standard. A number of studies actually show evidence of improvement in terms of availability of commodities. But this also is complemented with the prime vendor model, which was introduced alongside DFF to complement the Central Medical Store Department when they are out of stock. Facility can use the money within their bank account to go and procure to unaccredited private farmers. In terms of infrastructure improvement, in terms of renovations and the minor infrastructure improvement. In terms of planning and strategic purchasing, evidence are showing actual improvement in terms of facility level planning and budgeting, complemented with digital tools and the DFF guidelines and the planning guidelines. Transparency in terms of digital system, knowing what you're planning and what you're spending through the FAS, and that is quite transparent from the facility level to the district, region, up to the national level. They're able to see what is being spent and what is being planned, but also strategic purchasing with respect to allocation formula. Governance and accountability, community participation through the Health Facility Governing Committee, accountability also through the use of digital tools. In terms of autonomy, prioritization of local needs through the bottom-up planning, that is quite clear, but there is limited autonomy, especially in terms of deployment, because the personnel are managed centrally, with the exception of short-term employment with those short-term contracts. But also the limited flexibility in terms of trading off between PFM rules and the flexibility. So the PFM rules are constrained in terms of having the spending ceilings. Next. So in terms of the challenges, so far we have been observing delays in fund disbursement, which affects implementation on planned activities, which also leads to low budget execution. The second is about multiple levels of approval, which also slows access to fund and the use of funds, because you have to get through the Health Facility Governing Committee, take it to the district level, and then withdraw money and spend. So it's a lengthy process in terms of getting the approval. The third is about rigidity in terms of PFM rules and the spending ceiling, which limits flexibility and reallocation in terms of resources. So it's quite possible to do the reallocation in between, but it is a lengthy process. But also the between reallocation is even cumbersome to get that approval. The other challenge is about shortage of staffs, especially the lack of accountants, knowing that DFF also pushed a lot in terms of financial management, and you'll find most of the facility actually do have medical staffs who actually struggle in terms of how to manage the funds. This also goes together with the limited capacity in terms of financial management, and also the poor internet connectivity and inadequate ICT equipment. Next. So what are the lessons which comes from the experience in Tanzania? First of all, transfer of fund directly to PHC facility is quite important, especially in terms of reducing delay and improve responsiveness. Allowing flexibility with PFM rules, quite important to help facility respond to local priorities and need. The third is to strike a balance in terms of autonomy and accountability, which is quite challenging because you have to ensure accountability through strengthening and oversight, but also we have to push to have those sort of flexibility and autonomy, which could be quite challenging to balance. Investment in digital system is quite important. The way we have the plan rep, the FAS, which enhances in terms of accountability, but also transparency and tracking expenditure. Building facility capacity is something also important, especially if the facilities in charges have medical background, doesn't have financial accounting skills. Ensure timely and predictable disbursement is quite important, but also transparency through the use of allocation formula, which also accounts for performance, equity, and the need, which are quite important to ensure that facilities are actually delivering service which is needed. Over to you, PV. Thanks.
Thanks, Peter, and thanks, Nida. PV and Tom, thank you for your framing presentation. I'm Nirmala Ravishankar. I'll be facilitating and moderating this discussion. And so maybe first and foremost, I'll invite Sofa from Kenya to come in and reflect on some of the themes we've heard from, frankly, all three presenters so far. So the incredible promise and frankly, even the effects of facility financing in terms of service readiness, improved service readiness, but also the challenges, right? So delays in fund flows, the bureaucratic and PFM rigidities, at the facility level, perhaps limiting some of that potential. So, so far, how much does this resonate with Kenya's experience? And if you had any questions for our panelists, those are welcome as well. Over to you.
Thanks, Nirmala, and thanks to the presenters, Peter and Nida. Quite stimulating presentations there, and quite a lot of similarities to our own experiences. So just to reflect a bit on our own experience in Kenya, I'll start by giving a bit of history of the journey of facility autonomy in Kenya, and then reflect on what we are currently experiencing from the Tanzanian and Pakistan experience. So, I mean, facility autonomy in Kenya has gone, or the facility autonomy reforms has gone through what I call about 3 phases. The first phase was in the late 90s, late 80s, early 90s, during the structural adjustment program, when the government adopted what was popularly known as cost-sharing policies, which was basically the introduction of user fees at facility level, and then the government policy at that time then allowed for some arrangement for the facilities to manage the user fees collected there. So this went all the way to early 2000 in the MDG phase, where we had a bit of reform around that arrangement, which was largely donor-driven, and the idea was try to reduce the financial barrier to the cost sharing, so to reduce user fees but still maintain some level of finances. So the reforms that were adopted then were largely driven by or supported by donors, particularly Danida and World Bank. In early 2000, they introduced a similar arrangement to what Tanzania is going through now, what we call the direct facility financing, and this was organized around facilities removing, particularly primary care facilities, completely removing user fees, but then being reimbursed for user fees forgone through donor financing mechanism. And within that, then health facilities set up bank accounts and management arrangement or governance arrangement to manage those, and they were reimbursed on quarterly basis. And that continued then from early 2000 to around 2010, 2013, when we adopted devolution, and the entire landscape changed because the devolution laws, when we adopted county government, the constitution designated national government and county government as the only accounting entities that were responsible for managing government resources. So what we saw immediately post-devolution is majority of counties suddenly re-centralize financial management from primary facilities or from health facilities to county level. So we saw some sort of an intended consequence of devolution. So I mean, and then so the third phase of the reform is the post 2013. So there's been a lot of debate and lots of experience from different counties trying to reintroduce financial autonomy in different ways, using either local level legislation or policies. But in fact, more recently then, after a whole decade of trial and error, a national government new legislation was enacted in 2023 that now allowed for the framework for health facilities to actually maintain, particularly primary facility, to maintain and use and manage bank accounts and finances to some certain extent. So from that experience, just to reflect briefly on especially what has been happening post 2023 in the processes of implementing the new rules, we've seen that, and reflecting on or comparing with Tanzania and Pakistan, is, I mean, we are all trying to address the same problem. Is health facilities are receiving or managing funds without significant autonomy. The route that the countries are taken is slightly different. Kenya has taken a much more extreme legalistic route by implementing a legislation which is being customized or adopted in counties. Tanzania is doing this through a policy, while Pakistan is doing this from governance reforms. We're seeing different levels of autonomy, ranging from day-to-day operational financial management all the way to procurement to some level of HR management. We're seeing different levels of adoption of digitization. But interestingly, the governance arrangement actually at facility and community level, I've been listening to Peter and Nida across the different countries. It's almost similar. A few take homes or a few reflections to emphasize. One is the structural arrangement. As much as all the countries are trying to address the same problem, the route taken is different. Kenya took a legal route, Tanzania took a policy route, Pakistan has taken a more kind of administrative arrangement route, but and with different experiences across those. We've also seen in terms of the technical arrangement, I mean, health financing experts will be very happy with the Tanzania model. It looks both more technically sound, both from a PFM perspective, is more technically aligned to PFM regulations, but also from a health financing perspective, it actually adopts a better strategic purchasing approach. But then from in terms of the challenges, though, implementation challenges, there's significant similarities across Kenya and Tanzania. We are seeing resistance from other sectors, particularly the finance sector. So Kenya has been experiencing lots of delays in disbursement because of resistance of adoption of support from county treasuries. We're seeing the challenges Peter has highlighted about multiple approvals in Tanzania. Interestingly, Pakistan is noting over 20 steps of approval. We are seeing delayed release because of that. All countries are experiencing challenges with PFM rigidity, and this just speaks to the broader conversation and tensions between health financing principles and PFM principles. And then finally, we are seeing because of that, we think varied experiences in implementation. I think for me, the last point I want to make in this comparison is the take-home listening to Peter and Nida and reflecting on the Kenyan experience is that it just reminds us that financial autonomy or health financing autonomy, facility autonomy is not just a health financing intervention. It's a governance intervention that leads to changes in decision-making power and authority, and that brings about power, interests, and those need to be thought through when designing and implementing these reforms. So it's not really just about the design in terms of whether you're taking a legal route or policy reform route or administrative reform route. I think doing a detailed political economy assessment in trying to understand the local context will really help in proper design or proper implementation of these reforms. Thanks, and back to you, Nirmala.
Thanks so far. We had already a lot of interesting questions in the chat, and now you've added a few more. So let me see how we can manage in the time that's left. So I'm going to pick out maybe 5 themes that I think all the panelists, I'm going to ask them to speak to the 5. So first was this question from Abigail Chari about what is the extent of money that is actually flowing through DFF, right? Like, what is the quantity here? Because I think several presenters talked about the fact that several inputs like salaries, infrastructure are not flowing as financial resources to the facilities. And I think, Peter, you gave that statistic for Tanzania. You said about 20% was this operating cost that the facility controls versus 80% not actually being part of DFF. So one question, especially to PV, Nida, and Sofa, is that somewhat consistent with what you've seen in other countries? Is it roughly 80% is not DFF and 20% is DFF? Then second question, I think, was from Julio. How are these funds, DFF funds, allocated, right? I think, again, Peter, you preempted many of these questions. I think you gave the answer for Tanzania about, there was an allocation formula that brought into account population, remoteness, performance. So is that, again, common in the other countries? Is that the criteria that is being used? I think Julio also had a question about, are there controls over what facilities can spend their money on? And do we see that across different countries? And that, I think, leads nicely to a 4th question that's from Shufang, which is around efficiency of spending at the facility level. So right at the beginning, I think this framing was done around efficiency in terms of fund flow. And I think, Tom, you also talked about whether the functions are sitting at the right level, whether certain kinds of things, there are, benefits to having salaries and procurement done at a higher level. But there's also an efficiency question to be asked about what facilities are spending their money on, right? If they're spending it on beautifying the garden versus fixing the operating room, there would be a difference in terms of the impact on service delivery. So is that the next sort of frontier for this analysis? And then maybe the last question so far on the politics, right? So I was really hearing at the background, this tension between facilities and local governments. If local governments perceive facility autonomy as them losing some control, what are the implications of that? So those are the questions that I'm going to that I'm posing to all of you. And so maybe we can just go in the sequence in which you spoke in the beginning. So maybe I'll start, PV, with you, your reflections on these questions. Over.
So, in terms of how much actually flows through DFF, yes, in terms of trends, there's some commonality across the countries, particularly that the direct funding flowing to PHC facilities are smaller, but at the same time, there's also a difference either in the type of facility. For example, in Indonesia, where there's BLUD versus the non-BLUD puskesmas. And again, even in terms of across countries where, for example, in certain facilities in Burkina Faso or the Philippines, we only have access to petty cash, which is roughly around $200 a year. So I think, for example, what Tanzania did, what Pakistan did in terms of creating a new grant, what Uganda did, these are certainly like mechanisms which actually also ensured that facilities were able to gain access to additional funding, which led them to be more agile in terms of addressing operational matters. Maybe in terms of your question, in terms of efficiency, I think the question was more in terms of what studies can be done. And I think especially with the challenges in terms of data, sometimes we have to resort to special studies. But in terms of how it actually affects efficient service delivery, it's something that we're also reflecting as I was also reading through the past literature, where I think the accountability mechanism is that sort of push so that facilities actually become more efficient, especially since this was trying to solve the inefficient service delivery back in the 90s. But right now, with fragmented fund flow, I think that there's another problem in terms of then who is the facility actually accountable to? At the same time, there's actually no clear accountability mechanism. So it may be that it's actually not leading to efficient service delivery. And it's probably the other next frontier in terms of what we can further study outside of this. And certainly the politics. I think in terms of what was shared here, I think in terms of sharing the good results, and for us who are more into the brokering work, these are the things that actually can sort of reframe the discussion in terms of taking power to actually sort of being able to deliver the services, especially for the politicians. But again, it may be a challenge for us technocrats as well in terms of developing the actual mechanisms, whether having those simpler accounting mechanisms or the digital tools to ensure that the money is actually being monitored. So I'll stop there. You have a lot of questions for the other panels to also pitch in.
Thanks, Phoebe. But this financial visibility, right? So bringing greater visibility over the flow, especially in a fragmented context, is definitely a theme, I think, that is worth exploring further, whether that leads to greater accountability, greater efficiency, etc. Nita, over to you. Any thoughts on these questions?
Thank you, Nirmala. So in terms of the percentage of funds being DFF, I think it is also very small for in case of Pakistan as well. And we have two examples for that in KP particularly, and then elsewhere in other provinces also we can see. So PCMC itself receives a very small amount of funds, which can be compared to petty repairs, petty cash that you can have at hand. The similar model is in Punjab, which is health councils, and health councils have a regular funding, and they also receive need-based fundings for the operational needs that they have, and it is a distribution of money, an equal distribution of money over facilities, depending upon the type of facilities. So in terms of the percentage, I think I agree that it is pretty small, and it is only meant for those minor little things at the facility level that are required by the facility manager, who already has a limited capacity to deliver those, I guess. On the controls that the facilities can spend on, I think PCMCs has a detailed guideline, had a detailed guideline, which was meant for all the facility managers to guide them how to spend on. They have permissible expenditures, and they are very clearly outlined, and they can very clearly refer to the rules that they have to follow as well in these guidelines. Although with those guidelines, still we faced a lot of problems at the ground level, at the facility level, because the managers sitting over there are doctors. They don't have the skill set for procurement. They don't have the skill set for the public financial management, things that was spoken earlier. I think that capacity lacking over there is not surprising, but they delivering on those is actually a surprising expectation from them. So for that, we at in KP have been trying to deliver on the trainings that can actually make them aware of the basic principles that they need to follow. But as a next step, we also simplified the guidelines that were already in place, so that to make them, because it was actually leading to compromising the reform, as the facility managers were unable to spend the money, and their closing balances in their accounts was increasing, and they were not spending money because they were making mistakes in spending those money, and they were facing audit paras against it, which was actually compromising the reform, because the finance department was seeing that the facilities are not spending. And I'll make it clear over here that the money that goes to the PCMCs are non-lapsable funds. They cannot go back to the department back, for the finance department back. They don't lapse at the end of the year, and therefore it is only money parked in some account. So from a government's perspective, where they have different competing priorities, it is a problem. So I think with that control, I think simplifying of the guidelines has really enhanced the process of expenditure. And what the government now has done in the current year is that they have actually pinpointed the activities that the PCMCs should be delivering. So when I talked about in my presentation the use of data, now they have seen the data, and the distribution plan has been based on that data. And according to the data, they have identified 3 priorities. So one is the labor room strengthening. The other is, again, the infrastructure, because we have a lot of facilities which still have compromised infrastructure. And the other is the equipments. So now we have dedicated money going into strengthening the facility on specific areas, which previously was only left at the disposal of the facility manager, what he wants to do, because the data backs what we are spending now. To your question on the, I think I've covered the efficiency of fund flow of the facilities here, but on the politics, I think, as was mentioned and discussed earlier, for PCMCs, it is a more administrative reform than a local government influenced reform. Although there are local government members in the committee, which brings the local representation and the accountability as well to the grassroots. But I think in terms of controls, and it might not be political, but from the bureaucratic point of view, we have multiple layers of controls over there, where there is the IMU, as I spoke of. Then there is the DHO himself, who's responsible for all the facilities in the district. And also there's a third tier where the deputy commissioner, who's the head of the district, he has like all the departments. He also supervises and resolves issues at all. So I think accountability and controls are very well layered in terms of PCMCs, although it is not politically driven. I'll stop here and I'll hand it over to you.
Thanks, Nida. Peter, before you come on, I might change the question a little bit, both in the interest of time and recognizing that you answered some of these questions already in your presentation. Maybe I'll just take a sort of overarching question that again came from the audience about what lessons countries can take from this, because we're hearing a lot of very common challenges. And so are there some important lessons that other countries that are embarking on this journey should keep in mind? One that comes to my mind listening to both you and so far was maybe patience, since it's taken 10 plus years in Tanzania and even longer perhaps in Kenya to travel this road. But Peter, anything else from your side that you would share with other countries contemplating DFF reforms?
Thanks, Nimara. Yes, I would say it's still a learning process. Even in Tanzania, we are still learning, despite having, now we are almost getting to a decade of implementing. But a couple of things which are still to be revised or to be improved going forward. But I think the idea of trying to have that platform as it is, being institutionalized, I think that is quite important, because it will take years to revert back to that. But at least we have a platform as a starting point where people could align their funding flow in order to reduce fragmentation. And that has been the call actually to reduce the off-budget, to make sure that they tap into that DFF, because if you put it, it goes direct to facility. But also the idea of digital systems, of which I think is quite important. And despite having a company with some bottlenecks in terms of how to use, in terms of capacity going forward, but at least these are tools which are quite important to make sure that the funding is quite visible, transparent, guiding in terms of planning, knowing what you have to do, what you can't do, because you can't execute, the system will be denied to take you forward, and so on. So those are things which are quite important. However, I would say it's striking, as I mentioned previously, in terms of striking the balance between enhancing accountability of the PFM systems vis-a-vis granting autonomy. I think it's the big question which for many countries actually could struggle with it, the same here in Tanzania, because striking the balance is not that easy. You feel like you could allow to grant the autonomy and flexibility, but also you compromise in terms of accountability. The more you strengthen the accountability, you discourage the autonomy, the flexibility in terms of funding. So it's something which comes and go, and then it's something which people complain, but it's something which we need to figure out how to go about it to strike that balance.
Right.
But a couple of things which also so far I think has already alluded to, which are quite important also for other countries to take on.
Thanks, Peter. So this trade-off will continue and people will complain. So those are constants that everyone needs to have patience for. So far, final word, and we have very little time. So I encourage you to be brief in a minute. Any lessons for other countries from Kenya?
Thank you, Nirmal. I think I'll just make 2 points just to emphasize things which have already been said. One is for autonomy, it's really not about the technocratic design. It's really just about making sure that you align stakeholders around the common goal, and you need a balance between 3 things: what gets allowed to be done, which is the decision space, the capacity at the facility, and the accountability arrangement. And then the last point on the politics, my second point on the politics, I mean, there will always be that tension between when you are devolving power or decentralizing power, so between the person decentralizing and the person getting the power. And I think what we need to repackage this, especially for those of us who are supporting countries with these reforms, is to make the center understand that by them decentralizing decision making is not losing control, but it's changing their responsibility to more of an accountability. So they don't have to approve every expenditure, but then they can hold the facilities accountable. So it's just changing the power balance. So otherwise, thank you very much, Nimrata. Thanks.
Thanks so much so far. Great. I want to just thank all the panelists, and maybe with that, give the mic back to Nathan, who may be regretting having decentralized power to me since the discussion has taken much longer. But back to you, Nathan.
Not at all. That was wonderful. And I know that we could go on for quite a bit longer. Thank you very much, Nirmala, and thank you to all our panelists. Thank you to all of you who have stayed with us through the end. We have a great, healthy audience still. I'm not going to take time actually to go over this slide and closing reflections, but you can read them. And again, we will provide all the materials, the recording, the presentations, a synthesis. We've had a very rich Q&A, both live and in writing. We will clean that up, synthesize it all. That will also be there. If we missed any questions, apologies, but we will answer those offline before we post on our website. So again, thank you all very, very much. This was the third of our 4 webinars. We will have our 4th and final webinar on July 22nd on a very important topic, and we are going to be co-hosting this with the Center for Global Development, who has been coordinating a working group, a multi-organization working group on the financing of medicines and supplies. That relates to our webinar because we are finding that principles from our first 3 topics, the better use of data for strategic resourcing at the district level, better coherence of multiple purchasing schemes, and today's better efficiency and effectiveness from fund flows and facility financing all have an implication for the financing of medicines and supplies. So we're going to see those come together. Please watch out for that invitation. A save the date should go out today. You should receive it if you've registered for this one. Please register for that one and join us on July 22nd. Thank you again very much to ODI Global for this great work together. I hope you will all read. It's just been published today, a very long and very rich synthesis report and 6 country case studies, which we really hope will help everyone in those countries and everyone gathered here today. So thank you all very much and have a great rest of your day.